Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great. Thank you, Brian. Thanks, everyone. I'm very excited to be here. As Brian said, I'm hopefully going to be preparing some additional materials on topics related to substance use disorders, and please be on the lookout for some polls about what folks are interested in hearing about. But today I'm going to talk about a topic I've been interested in for a while, which is telemedicine delivery for substance use disorder treatment, in particular opioid use disorder. And as Brian mentioned, I'm a general internist and primary care doc at Harborview and an addiction med doc at Evergreen Treatment Services, which is an opioid treatment program. They have several clinics throughout the state, and we've been doing telemedicine delivery for about 5 years now. But it is a rapidly changing landscape now, of course, in terms of COVID and social distancing mandates. So I'm hoping today mainly to review regulatory changes, the flurry of regulatory changes that affect telemedicine that occurred in the spring, and talk a little bit about the evidence, though there's not much, for telemedicine delivery of treatment for opioid use disorder. I don't have any disclosures. And I already mentioned this. Just to frame the discussion, a brief discussion of a case. You're working from home via telehealth to maximize social distancing. I don't know if this applies to anyone listening in. Your next patient is a 64-year-old man new to your practice with well-controlled HIV and moderate COPD who's been using heroin for the past 18 months and is interested in treatment. What do you do? What are you legally allowed to do? How would you approach this patient? Another case I'd encourage people to think about is patients who are already in treatment. If you're providing buprenorphine treatment for opioid use disorder, patients who are routinely seeing you in person at a certain frequency, have you adjusted, or are you thinking about adjusting those treatment visits and using remote visits at least part of the time? So we'll jump right in and look at some of the regulatory changes that have occurred. This slide is a good kind of summary of most of these changes that occurred in pretty early on in the epidemic in March. And we'll go through and highlight most of these in detail, but in March 16th, the DEA made prescribing of controlled substances more available over this modality. And throughout the rest of the month, there were a lot of other changes that we'll dive into now. So as far as the prescribing of controlled substances, I'm going to, for each of these, have a little snapshot BC before COVID and then after COVID. The Ryan-Haidt Act of 2008 amended the Controlled Substance Act of 1971, and it was in response to a young man, an 18-year-old high school student in California who died as a result of an overdose, controlled substance overdose. And he acquired those substances from a kind of rogue online pharmacy. And this act was designed to shut down those types of pharmacies. And it was very effective in that, but it did have some unintended consequences as far as ability of practitioners to treat opioid use disorder for one, or other disorders that involve controlled substances provision. And it required, among other things, that before a controlled substance is prescribed, at least one in-person medical evaluation of the patient needs to occur. Now, there are some telehealth exceptions to this, but they're generally pretty narrow and technical. And as a result, this has pretty well limited the ability of folks to be started on treatment, for example, with buprenorphine for opioid use disorder, without an in-person medical evaluation. Now, one of those 7 exceptions is actually a federally declared public health emergency, and that emergency was declared January 31st, and it's renewed every 30 days, and last was in October. And the DEA actually gave explicit guidance on March 16th that registered practitioners could, in fact, prescribe controlled substances without an in-person evaluation if they are using telehealth, essentially, two-way audiovisual real-time communication, and acting in accordance with federal and state law. A couple weeks later, at the end of March, they provided additional guidance that actually singled out buprenorphine and said that during the public health emergency, you could prescribe buprenorphine based on a telephone evaluation without an in-person or telemedicine evaluation, provided you felt that an adequate evaluation could be accomplished by telephone. So we went from a pretty regulated use of controlled substances to a pretty liberal interpretation of what's needed as far as establishing a patient-doctor relationship to prescribe these medicines. Other changes that you may be aware of involve reimbursements, and whereas prior to the CMS waiver, Medicare patients had to be in a designated geographic area known as a rural health professional shortage area, and they actually had to be seen at a local medical facility, not in their homes, in order to get reimbursed for telehealth visits. And Medicaid and commercial insurance was a whole patchwork of different coverage situations. But there's been a substantial expansion, removal of these geographic and originating site restrictions. Beneficiaries can now be seen in their homes, and reimbursement rates are the same as fee-for-service in-person rates, and there's an ever-growing list of payable service codes. Some changes in March also around HIPAA compliance for telehealth. Essentially, the Health and Human Services Office have said that they won't impose penalties for non-adherence with regulatory requirements under HIPAA in connection with good faith provision of telehealth. So this opens up to a whole bunch of platforms where those platforms don't offer business associated agreements. So FaceTime, Google Chat, really any video platform that's not public facing is fair game if you're unable to have a more traditional HIPAA compliant platform for telehealth. A few other changes that I'll just mention briefly. 42 CFR Part 2 is a patient privacy provision in federal law that applies to substance use disorder treatment programs and is more stringent in protecting patient identifying information than HIPAA. And SAMHSA, the governing authority, has allowed those restrictions to be waived in cases of medical emergencies during this period. SAMHSA has also allowed opioid treatment programs to provide a lot more take-home medication of methadone in opioid treatment programs, as well as to perform some portion of their assessments by telehealth. And the DEA has waived the requirement that someone obtain a DEA license in each state in which they practice by telehealth. I do want to mention that these are federal changes. State-specific laws are varied and they may impact some of these questions. And some states do have laws which are more stringent than the federal laws. And I want to direct you to these two really great resources, the Center for Connected Health Policy and the Federation of State Medical Boards, which have really user-friendly ways of looking up your state's particular regulations when it comes to telehealth, and particularly controlled substance prescribing over telehealth. So that is a rapid tour of some of the regulatory changes that occurred in March that have made telemedicine delivery of treatment for opioid use disorder much more feasible. And I want to turn now to what we know about its efficacy. And all of these studies are prior to the pandemic. As far as telehealth for chronic disease management, there are numerous studies, systematic reviews, and meta-analyses of telemedicine for several mental health conditions, notably depression, PTSD, and dementia. These generally show no less effective compared to in-person treatment and are associated with high patient satisfaction. There's long been interest in telehealth for opioid use disorder, given the effectiveness of medication treatment for opioid use disorder, juxtaposed with the poor penetrance of treatment all over, but particularly in rural areas where distance to care is a major barrier. But despite that interest, there's been relatively little adoption of telemedicine. This one particular study looked at commercial insurance claims from 2010 to 2017, and less than 0.1% of all substance use disorder visits during that time were conducted remotely. There was a systematic review published in the Journal of Substance Abuse Treatment in 2019, which looked at the last 20 years of literature on telemedicine delivery of care for substance use disorders. They found 13 studies, which met their inclusion criteria, 3 for tobacco, 5 for alcohol, and 5 for opioid use disorder. Among the opioid use disorder studies, 2 of them were focused on psychotherapy or chemical dependency counseling. These were small studies with ends in the 30s to 60 range. And these were patients who were already on methadone maintenance treatment, and they were randomized to either receiving chemical dependency counseling remotely or in person. And there was no difference in the number of sessions attended or change in the percent of drug-positive urines. And there was no difference in patient or therapist ratings of therapeutic alliance. The other 3 studies looked at medication management for opioid use disorder. They were all retrospective and non-randomized. And in all studies, crucially, the patient was not at home. The patient was seen in a remote or rural clinic, but the prescriber was remote. And there were other components of care, including urine toxicology screening and counseling. The largest study was over 3,500 patients in Ontario, Canada. And I will say they've been doing a lot of telemedicine in Canada for opioid use disorder for a long time. And this was, again, among methadone patients, and this was not randomized, but patients that didn't have ready access to a methadone practitioner were seen by telehealth, and they compared this to the in-person group. They actually found that the retention in treatment at 1 year was significantly greater in the telehealth medicine delivery group. I'd caution people in making the leap that it's more effective in retention and treatment. I think this is more reflective of the differences in the groups in this non-randomized study, where most of the telemedicine patients were in more rural areas, and actually their degree of addiction, if you look at the kind of baseline characteristics, probably had less severe disease in general. There was a study in Maryland without a comparison group, basically looking at retention and care for telemedicine delivered buprenorphine care, and it had a 50% retention at 6 months. Again, there was no comparison group, but that's pretty par for the course with these types of buprenorphine programs, 50 to 60% retention in care at 6 months. And there was a study in West Virginia among 100 patients, about half seen in person, half via telehealth, and they found no difference in time to abstinence or 90 or 1 year retention in treatment. So the conclusions of this review is that while there's robust evidence for telemedicine in certain chronic mental health disorders, the evidence is much more limited in substance use disorders. There are some indicators of comparable therapeutic alliance in retention and care, though there's small sample sizes and not powered to detect non-inferiority. And we need more data on telemedicine, particularly telemedicine with the patients at home, and more information on quality and outcomes. But the author's conclusion is telemedicine-delivered treatments are a promising alternative when in-person treatments are not readily available. And that's certainly the case now, where with case counts climbing, and the American Society of Addiction Medicine, major professional society, has recommended leveraging telehealth for patients with opioid use disorder, given this evidence and concern for harms of treatment, which in normal circumstances has a pretty high degree of patient contact. I do want to point out some remaining barriers and concerns to adopting telehealth for treating opioid use disorder. Adhering to state laws is, again, complicated and a moving target, and you want to make sure that your state doesn't have more stringent laws in these areas. Uncertainty about whether these new regulations will last. Many of them are tied to a state of public health emergency and will expire when that's no longer renewed. And there's a lot of questions about how to do this well. There's a lack of clinical guidelines on high-quality practices, how often or if you should be getting toxicology testing in this setting, how to respond to patients who may need a higher level of care or aren't responding to treatment, and how to engage patients in care where there are technological barriers, no Wi-Fi, no smartphone, to telehealth. So just want to leave you with these take-home points. Telemedicine-delivered care is understudied, but evidence suggests similar efficacy in terms of retention and care and establishment of a therapeutic relationship. A slew of emergency regulatory changes have made it easier to treat opioid use disorder by telehealth, including make it possible to prescribe buprenorphine to a new or existing patient by telehealth or telephone. But barriers to uptake remain. But I think there's excitement. There's quite a bit in the works in the legislature about making some of these changes permanent. And I think there's excitement that this could kind of be a turning point in terms of using telehealth to really promote access for folks struggling with substance use disorders, particularly in rural areas where they might otherwise have trouble accessing care. I have my references listed here and some great resources. I want to point out PCSS Now, which has several modules on this topic that go into far more detail, and the American Society of Addiction Medicine COVID-19 Task Force recommendations has documents relating to telehealth for addiction services, which are pretty inclusive, and then SAMHSA and the DEA's information pages as well. And that's what I have prepared. I have cut out, unfortunately, the discussion of actually the nuts and bolts of conducting a telehealth visit. If there's interest in that topic, I think it could merit a whole session and discussion, but I'm happy to answer questions about that or any of the material I presented today as well.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.